word floating knee actually was first introduced by McBride and Blake in 1975 for ipsilateral fractures of the femur and tibia, where the knee is completely disconnected from the rest of the body. And if you see, they are usually a result of high energy trauma, which Dhaval was just saying. Most of these injuries are actually high energy trauma. This was the classification which is usually used by Fraser. It has been done by Fraser. Type 1 is the diaphyseal fractures of the ipsilateral femur and tibia. So you have it in the diaphysis mostly. And the type 2 is a combination of diaphyseal and intra-articular injuries, or it can be both intra-articular injuries. So type 2A, diaphyseal fracture of the femur and intra-articular fracture of the proximal tibia. Type 2B are intra-articular fracture of distal femur and diaphyseal fracture of the tibia. And type 2C are the combined intra-articular fractures of distal femur and proximal tibia. So in this, the type 1 is the most common one. And I was just showing what we should look for in these patients, because these are high energy trauma. So you always look for any associated injury. And there is about 50 to 70% incidence of open fractures, and it is mostly tibial fractures, which has a higher frequency of being open. And the injury to knee ligaments is also commonly found. So one has to keep it in mind. If you can see it clinically, fine. If it's suspected, then you should get an MRI done to see whether there is any ligamentous injury. And also there are high chances, because it's a high velocity trauma, again, chances of neurovascular injury. And also look for whether severe head injury, chest injury, and other associated fractures are common in these patients. So there is a treatment algorithm which was given by Bertrand et al. Like the patient with a stable, the patient with a floating knee is in stable condition. Then if it is a closed fracture, then you can think about a definitive fixation. But if it is an open fracture, then you have to think about, again, an external fixation, or depending on the type of the grade, you can go ahead with a definitive fixation with primary debridement. That depends on your choice, how you want to do that. Now, if the patient is in unstable condition, then again, like even in bilateral femur fractures, which you have done, which have seen that we do a damage control DCO. So do an external fixation. Then if there are clinical indications of any ligamentous injury, then do an MRI, and then later on go in for definitive fixation. Now, what type of definitive fixation can be done? In just diaphyseal fractures, if there are MRI or clinical signs of any ligamentous lesion is not there, then one can go with a single incision, retrograde femoral nailing, and anterograde tibial nailing. If in the diaphyseal fracture there are signs of or MRI suggestive of ligamentous lesion, then you should think about an arthroscopy. You have to keep it in mind. So it is better to do an anterograde femoral nailing and anterograde tibial nailing, and do a ligamentous reconstruction after recovery from the bone lesions. And in the other, if there is an epiphyseal fracture, then again, you obviously have to do an open reduction and internal fixation. Epiphyseal means, what I mean is that if there is an intra-articular injury, then obviously your main consideration is your articular reconstruction. So there has to be open reduction, anatomical reduction, and internal fixation. So let's I'll show a case which there are definitely a few cases, but this one this is 24 years old male involved in a RTA, again, high energy trauma. There's a fracture shaft to lower 1/3 of the femur with a butterfly fragment. There's also a segmental tibial shaft fracture. Patient also had a transverse fracture of the patella, which is not seen in this X-ray, unfortunately, but this patient also had a patellar fracture. This patient was hemodynamically stable, and this is a type 1 injury. But also, as I said, this type of high velocity trauma, you should also look for other associated injuries. And this patient also had a T-shaped acetabular fracture. So that also we had to keep in mind, because again, depending on what are the fractures or injuries are there, you have to take in consideration for your positioning of the patient while operating. So that's what we look at. So in pre-operative planning, we thought about a single incision, so retrograde femoral nailing in this patient and anterograde tibial nailing. And because there is a transverse fracture of the patella, we thought about a tension band wearing. Now we can think which one to do first. As you say, with the retrograde femoral nailing, because there are high chances of injury to other soft tissues. So it is better to take care of the femur fracture first. We do a retrograde femoral nailing first, and then an anterograde tibial nailing, and at the end, tension band wearing of the patella. In the same single incision, we can do it in a supine position. And so once you have done that, either you can do in the same sitting the fixation of your acetabular fracture, because this was a T-shaped fracture. We could do it in KL approach for this fracture which had shown. So again, the position had to be changed into semi-prone position and fixation accordingly. So this was the post-op X-ray. I'll not, there's a very poor X-ray just a long time ago. And you can see we have not touched the butterfly fragment. We just left it just like that, because this was a close nailing which we had done. Even the tibial nail, we had used an unrimmed nail in this. And we had done the acetabular fracture with the KL approach. And this is the post-op X-ray. This is 6 weeks post-op. As you can see, there is already starting of some callus formation there. Looks in good position there. This 3 months post-op, the fracture is uniting well. Even the butterfly fragment, it was quite displaced, but we haven't touched that. And it is still uniting very well. And this is 3 months post-op for the acetabular fracture also, which is healed well. And this is 1 year post-op. All the fractures united very well. So to take home message is, these floating injuries are usually a result of high energy trauma. So always follow the ATLS protocol, because they can have associated injuries which will definitely take precedence to look after. So always look for associated injuries which will play a significant role in surgical decision making. And this type 1 injuries can be effectively treated with a single incision, retrograde femoral nailing, and anterograde tibial nailing. And the others I've already discussed what type of approach you can do depending on the type of fracture we're dealing. Thank you.